This is Selma Schimmel at ASCO 2011 in Chicago, where our discussion continues with some of the most noted oncologists and key opinion leaders reporting on different areas of cancer, all cancer types, here at the ASCO meeting. And now we're with one of our group room regulars and favorites. In fact, he is our GI cancer key opinion leader, Dr. Professor Heinz-Josef Lenz, Associate Director for Clinical Research and co-leader of the Gastrointestinal Cancers Program at the USC Norris Comprehensive Cancer Center, Professor of Medicine and Preventive Medicine at the Keck School of Medicine at the University of Southern California in Los Angeles. I want to ask you about pancreatic cancer.
Yes.
Anything happening in that arena?
Not so much. I think we are learning to accept that when we get new drugs, such as cetuximab, bevacizumab, throwing in clinical trials, did not actually meet our expectations. We were hoping that these new targeted drugs would change outcome. I think it forces us to go back on the drawing board and maybe to understand and really classify pancreas cancer in a completely new way with the new technologies developing. Because that at the moment is our biggest hope for success, to understand what potential pathways are driving pancreas cancer. Do we have to rethink the potential new approaches? There are some promising new drugs being developed for pancreas cancer, but we are not even close that this comes on the market. There is one clinical trial particularly important, which is the Abraxane-gemcitabine combination, because that showed significant promise in phase 2. So we will have to wait for this. But for the novel drugs, which actually targeting not only the tumor, but the microenvironment, I think will have some potential benefits. Because pancreas cancer is a very unique cancer which interferes with the local environment, creates an inflammatory response, and there are now new drugs which interfere with that process. And I think that is probably a more promising approach in order to deal with this very difficult cancer.
Esophageal cancer, another difficult GI cancer. And these patients have to go through quite a lot. Yeah. Surgery, radiation, chemotherapy, and what about the integration of targeted therapies?
Yeah, so for esophageal, the GE junction, so the space between the esophagus and the stomach, is the fastest growing cancer in the Western world.
Why?
So there are a lot of speculations. One of them is that the use of antacids. So a lot of patients have reflux, mainly based on their diet. And when you stop the acid production, you may have more biliary reflux. Now, bile is not an easy substance. It's actually carcinogen. So it can actually induce ongoing inflammatory changes in the mucosa, eventually going to cancer.
Like erosion?
Mm-hmm. So they have erosive gastritis, they have Barrett's esophagus, and eventually it can develop into cancer. That's one of the hypotheses.
So you raise a very important point on the prevention or warning sign level, which is if a patient is having to take more and more antacids, you need to get to the root of the problem and not just assume after continued use that this is just simple heartburn.
Yeah, I think, and there is ongoing now discussions, as you know, certain ethnicities, like in Japan, gastric cancer is being screened, not colon. Now they're changing it for colon because of increase of colon cancer. In this country, we may have in the future to be developing better screening guidelines for gastroesophageal cancer. But I think one of the symptoms, when you have ongoing reflux symptoms or heartburn, which is not controlled or requires ongoing treatment with this over-the-counter medication, you need to have an evaluation with a gastroenterologist. I think there is no doubt about that.
One of the cancers being presented here data-wise is GIST. Most people don't know what GIST is.
So GIST is a very unique tumor, a very rare tumor. It's called gastrointestinal stromal tumor. It's actually not a cancer, it's a sarcoma. It comes from cells which are not epithelial cells. The most common site for GIST is the stomach. That's the reason GI oncologists seem to see these patients and treat it. Now, there is something very unique about these tumors because they have one driving mutation, one major intersection. Not 2, not 3, not 4, 1. And this intersection is called c-KIT. That's the mutation which makes this tumor develop, grow, and at the same time sensitive to treatment. Because we have a drug called imatinib or Gleevec, which inhibits exactly this intersection. GIST is the example of modern drug development.
And if I recall, Gleevec made news several years ago for a blood cancer.
CML, because it has also an effect on another oncogene found in CML. So after that, now that is an example I use always for medical students and for my residents and fellows. With this drug, because these tumors basically all have this mutation, the success rate is 80–90%.
Amazing.
So we have a mutation, we think the drug, story, finished. It's not. Now we know that the mutation, depending on the site of this particular gene, exon 9 or X11, makes a big difference. Prognosis is different, the sensitivity is different. So for exon 9 mutation, we give double dose. So that is where it's biology one-on-one. To know the mutation is not good enough. You need to know the characteristic of mutation. Because depending where this genetic change is in this gene, the function of the gene may be more or less. So you need more or less drug. And we even know how this gene responds to this treatment by generating additional mutation under the treatment, where we have additional treatment developed. So GIST is a wonderful example because it makes it easier because you have one particular gene. There are others now being developed, but less frequent. A wonderful example for modern drug development and molecular biology of particular cancers or tumors.
One other GI cancer, liver cancer.
Yes. So liver cancer will be a challenge for our country in the future because we will have not seen the tip of the development of HCC because of the infection with Hep B and Hep C. I think what we have learned over the years is that hepatitis B or hepatitis C induced cancers are different. We know that HCC develop in Asia and the US are different.
Are the differences environmental? Is it what we ingest, food,
I think that
preparation?
I think certainly how the disease develops, but just when you have a different virus inducing cancer, if it's Hep B or Hep C, it will be a different kind of cancer. It will respond differently. It will have a different prognosis. Some will change dramatically the normal liver into a fibrotic or cirrhotic liver, and others don't. Now, everybody has very easy time to diagnose HCC in the liver because it's characterized. It's typical. You don't need pathology by the way its vascular looks at the CT scan. It's a lot of blood vessels in it. And how it goes in and out and washes out with the contrast is so typical, that's the diagnosis. You don't need histology. Now, this makes it, of course, particular disease develop treatments attacking these blood vessels. And that's the reason we see that sorafenib, which is an inhibitor of receptors responsible for blood vessel formation, are successful. That's the reason bevacizumab is successful. So I think you can see that the biology and the understanding what makes the tumor grow will be for us the future success for more effective treatment.
So in summary, especially in the area of GI cancers, it's a very fertile cancer for, as you had used the metaphor of the highway, that these patients, especially with more advanced disease, have every opportunity to take advantage of this emerging area of targeted therapies that are very unique to the GI cancers.
The key message is stay tuned. We will in the next couple of years see a dramatic influence of the molecular understanding which translates directly into clinical benefit using drugs which are targeting very specific genetic alterations, and we will select patients we will benefit most of it.
Thank you, Dr. Lenz, really for being a forerunner in this area of research and for sharing your time with us. Associate Director for Clinical Research, co-leader of the Gastrointestinal Cancers Program, USC Norris Comprehensive Cancer Center, and Professor of Medicine and Preventive Medicine at the Keck School of Medicine at the University of Southern California.
And Salma, I couldn't thank you much because I think this is so critical for your viewers to see what's going on and maybe feel a little bit the excitement that there is so much to come which all changes the lives of our patients. Thank you.